Welcome to Wellness Wednesday. This is a special series produced by the Society for Integrative Oncology. My name is Lee Leibel, and I'm very pleased to be your host today and for every Wednesday at 12 o'clock Eastern through Labor Day. We have a really exciting program scheduled for you today, and we're waiting for one of the panelists who got kicked off just a minute ago. So this is the benefit of practicing mindfulness and yogic breathing. So I am the co-chair of the Yoga Special Interest Group for the Society for Integrative Oncology. And I also work at Columbia University Medical Center in New York. I work with cancer patients across the continuum, designing mind-body practices to help them manage side effects from treatment and to improve their qualities of life. So the topic today is especially dear to me. It is bringing mind-body practices to the chemotherapy infusion center and to the hospital bedside to better manage cancer patient distress. And this is a team effort in order to do this. My guests today, I'm very excited to have. They are a dynamic team. I'll go ahead and introduce Tina Walter while we're waiting for Gigi Robinson to dial back in. Tina is a certified yoga therapist who specializes in oncology. So she has had advanced training to work with the unique challenges of the cancer population. She works in the chemotherapy infusion center, delivering evidence-based interventions, breathing, mindfulness, meditation, and gentle chair yoga, gentle movement, while patients are undergoing their infusion. She also works inpatient in the hospital at the bedside with the palliative care group, and many of her patients are end of life. Many people might be surprised to hear that integrative therapies really can be used across the care continuum. There's something in the toolkit from diagnosis through treatment, through the different stages of survivorship, no evidence of disease or living with chronic disease, and also end-of-life care. So Tina works for 3 different hospitals. 2 are in Cincinnati, Ohio, and 1 is in Edgewood, Kentucky. So in Cincinnati, it's the Christ Hospital and also the University of Cincinnati Barrett Cancer Center. And just across the border in Kentucky, she works at St. Elizabeth Healthcare. So Tina, why don't we jump in and get started while we're waiting for Gigi to dial in. And I'll just tell the audience that Gigi Robinson is a clinical oncology nurse specialist. And she's dedicated to patient-centered care. She's had a 26+ year career working inpatient and outpatient with research and really advocating for integrative therapies being incorporated into standard care. So she'll be joining us shortly. Tina, hi.
Hi. Hi, nice to see everybody. Thank you for having me today. And I just want to say that Gigi, when she gets on, is going to talk a little bit about the history of this program, how it was developed within the hospital, some early background, and also she's going to talk a lot about distress at the end. But I wanted to just start by saying it's just an honor to do what I do. It's the best job. I love it so much. It is hospitals are #1 really profound places of brilliance and joy and happiness and sadness and loneliness. And every day there's so much emotion amongst the patients. Working with the staff has been such a wonderful honor for me. There's so much brilliance within these cancer centers. And then to just personally meet patients one-on-one is such an honor. Every day I get in my car and thank God for this job, because you learn so much about people, about yourself. I'm sometimes meeting people when they're the most vulnerable, sometimes at their first day of chemo. I am delivering these practices at the infusion chair when I'm outpatient, and then bedside when when patients are admitted into the hospital. So very similar types of areas of the hospital. In other words, I have to kind of do a dance between administrative needs amongst the staff, the nursing staff. Oftentimes I am walking into a room when when nurses are hanging the chemo, so I know that I'm not going to be able to do anything for at least 15 minutes, maybe sometimes. I'll have to come back. So I'm always kind of juggling between the different patients. And in the outpatient center, I'm also juggling a lot of times between family visits and lunch. A lot of patients are on their computers doing work during their chemo. So I'm kind of, walking in during a very busy time. So the outpatient unit is a very busy unit. In both units and throughout the practice daily, I am first developing therapeutic relationship with the patients. And that is the number one most important thing, the introduction. It's cold calling. I walk into the patient, and most of the time this isn't referred. Sometimes through palliative there are referrals, but most of the time I'm introducing myself as an integrative specialist from integrative health, and asking if they would like to participate in an evidence-based practice. And a lot of times it's education at that point, because people are like, yoga, I can't do yoga right now. So I have to educate that this is a lot of times breathing for relaxation. It is an intervention that they can use at home. I try to teach everything in a way that there's not only the how to do it, but the why to do it. There are so many physiological processes that these patients are going through because of their disease that can be benefited through yoga practice. So I can teach a breathing practice that will be beneficial, or some movement possibly, or some guided imagery, or something more deeper relaxing like a yoga nidra. So I have a variety of practices that I use, both inpatient and outpatient.
Audio. Darn it. Wait, I'm not in.
You have to turn off your phone.
Okay. Can you see me?
Yes.
Yes.
Okay. I can't see you, but that's okay.
Okay. Well, thank you, Tina, so very much. And welcome, Gigi.
Thank you.
Let me give a quick introduction. This is Gigi Robison. She is an oncology clinical nurse specialist. And she, for 26 years, worked at the Christ Hospital in Cincinnati, Ohio. She was an advocate for patient-centered care and for incorporating integrative therapies into the chemotherapy infusion center and into the hospital setting. She has been the principal investigator on numerous research projects around yoga therapy and cancer, and also massage therapy, oncologic massage therapy. And she has published numerous manuscripts on her research and on these topics. She is starting a new job in a few weeks, which I'm happy to share. She'll be moving just across the border just driving across the border for the new job at the St. Elizabeth Healthcare in Edgewood, Kentucky, where she will be continuing with the oncology clinical nurse educator role. So Gigi, so excited to have you here today, and I apologize for the Zoom technology that threw you off 1 minute before we went live. So welcome. Just to tell you what we've done so far, Tina jumped right in and started talking about her experience in the chemotherapy infusion center. So if you would like to pick up and maybe talk about how you two are a team and how you collaborated to get this robust program going at the Christ Hospital.
Sure. So it all started back in 2009. We had a family of a cancer patient, and the patient had died, and they donated $5,000 to Christ Hospital. And they said that the purpose of it was for complementary therapies. So we contracted with a massage therapist, and the massage therapist agreed that she would provide complementary therapies for our oncology patients. We did a literature search, and as part of the literature search, we identified different studies for measuring effectiveness of the massage therapy intervention. And we looked specifically at pain, fatigue, anxiety, and nausea. And we created a survey for patients to do before and after the massage therapy. We started that in 2010 in the cancer center. And then in 2012, we started massage therapy in our inpatient oncology area. In 2015, we decided to add yoga therapy to our integrative therapies, and we contracted with Tina. And Tina was a wonderful addition, and we collaborated to, again, create a survey for patients. And we used the 4 symptoms I mentioned before, plus we used distress. And the reason we added distress is because that was one of the American College of Surgeons in their standards, is that they want cancer centers to measure distress in their patients. And so we added that as one of our outcome measures. And Tina started off in the cancer center, and she would go chairside and provide yoga therapies such as relaxation, guided imagery, movement to patients in chairside. And then in 2018, Tina moved to inpatient oncology to patients' bedside. And meanwhile, Tina is collaborating not only with myself in order to do the research, but also with the staff nurses, because for each of the patients, they might have specific things going on. The doctor may have just given them bad news for the day. They may be experiencing a really significant symptom. And so Tina would collaborate with nursing to identify, if today would be a good day or not to do the yoga therapy. And also Tina collaborated with our palliative care team, because she provided yoga therapy to patients at end of life, which they just loved. So, Tina, have you talked yet about some of the similarities in your practices, yoga therapy practices, between inpatient and outpatient?
I have. Mostly, I talked about always building therapeutic relationship, because trust can never be assumed. And I think you have to really do a lot of active listening and validating. So I feel like, and that's really yoga. I mean, I feel like yoga, the word yoga means union, and to really capture that healing, I think listening is so much a part of the whole process of yoga. And I mean, listening is probably the most wonderful thing I think I can do for a patient. So I really listen in both areas and just try to find out what people's challenges are. For the most part, oftentimes it's not the cancer, but it's the fact that there are family members there and they don't want their family member there because they make them too nervous, or they don't want to deal with the financial portion of their life, or their granddaughter is giving them fits, or it's always something. So oftentimes the anxiety stems from other things other than the yoga, or other than the cancer. So I will develop interventions based on that. Sometimes it's pain I'm dealing with a lot. That's the people's biggest challenge, or sleeplessness, insomnia. Oftentimes it's anxiety, or oftentimes it's nausea. So it all depends on what I'm hearing. And then I select something very individualized, which is very personalized for people.
Right. And I would just like to reiterate that about Tina is I think that one thing that made her yoga therapy very effective, both inpatient and outpatient, was the fact that she did do active listening to identify, their major symptom. And then, for example, if their major symptom was anxiety, then she may choose to do a yoga nidra. If Tina chose to do a guided imagery, she would talk to the person specifically to identify, what location, what sights, what sounds would be pleasing to them, so she could individualize the guided imagery. And then Tina, can you talk about some of the differences between yoga therapy provided inpatient and outpatient?
Yeah, I think some of the differences mostly would be the inpatient, I have less time. I'm sorry, outpatient, I have less time because a lot of family and a lot of people are getting their chemo. It's a quicker kind of in and out kind of feeling that people have there. They go with their computers, with their work, often with their family. They're meeting friends for lunch. The food is very good in some of these hospitals. So the food comes in and they want to spend less time. It's more of a quick in, quick out. Family dynamics, a lot of people. I think the inpatient is a lot more time with patients. I can spend a lot more time. Much higher acuity. People are a lot sicker up in the inpatient unit typically, unless they're there getting a type of chemo, perhaps, where they're not so sick and they're standing and walking around. Then we might do some movement yoga if they can stand and want to do some mountain poses or some poses to build strength and balance. But most of the time people are in bed. In both units, inpatient and outpatient, safety and comfort is always the number one key. I always try to provide props, warm blankets, pillows for the head, looking at the patient so that I can get them as comfortable as possible. The inpatient unit can sometimes be a bit more challenging just because of the acuity level. People have a lot more pain there. So I'm spending extra time on the head with pillows, with warm blankets, pillows under the knees, anything I can do to get them comfortable, and anything I can do to create an ambiance that, quite frankly, sometimes people are shocked. It can be so nice when I dim the lights, when I can get them warm, when I can get them comfortable, when I can turn on maybe a small bit of music for them, and create a condition for healing, create a condition for relaxation.
Very nice. Okay, so I would like to thank you for that, Tina, because I think that one thing I can say from observing you providing the yoga therapy as well as hearing feedback from nurses is that they were very pleased with how you did provide comfort and safety and the patient's high satisfaction, and that was really important for us also. All right, so the two things we wanted to talk about today, one was we wanted to talk about the teamwork of the yoga therapist and the nurse. And I think that one thing to remember in a hospital setting, I think it's very key that there is that close connection between nursing and the integrative therapist, because it really helps to skid the wheel so that the yoga therapist or the massage therapist can be effective in their work. The next thing I'd like to talk about is distress management. And I would like to give the definition from the National Cancer, the NCCN. And the definition is: distress is a multifactorial, unpleasant experience of a psychological, i.e. cognitive, behavioral, emotional, as well as social, spiritual, and or physical nature that may interfere with one's ability to cope effectively with cancer, its physical symptoms, and its treatment. Distress extends along a continuum ranging from common normal feelings of vulnerability, sadness, and fears to problems that can become disabling, such as depression, anxiety, panic, social isolation, and existential and spiritual crises. So that is the definition. And I just wanted to say that the NCCN has actually updated their guidelines related to distress management to February 2020. And I would recommend, if anybody was interested, to go to the NCCN website and download their guidelines. This is something that the American College of Surgeons, when they're doing their hospital accreditations, they do follow NCCN. And one thing I would like to say from a hospital standpoint is that with distress, this is looked at on a scale of 0 to 10. And I'm going to hold this thermometer up and I'm going to say, can you guys see the thermometer? This distress thermometer, can you see it?
No.
Hold it up higher.
Hold it. Yeah. There you
go.
Closer to the camera. Yeah. Okay, good.
So this is the distress thermometer, and you can see right here how it's a scale of 0 to 10. And you can see over here all the different things that are looked at to monitor distress. So when looking at distress, it includes practical problems like childcare, food, housing. It includes family problems, emotional problems such as depression, fears, anxiety, spiritual and religious concerns, and then physical problems. It could be any of the symptoms. And so that's important to know because distress is a large category. So for example, at Christ Hospital, when the nurses would assess for distress, it would be on a scale of 0 to 10. Maybe the patient would say their distress is a 6. Then that would require the nurse to come back and ask additional questions like, can you tell me more about your distress and why you gave it a 6, why you rated it a 6? And they might say because of my anxiety or because of my pain. And so then again, that would help us to identify what the specific issue was. And we were talking about teamwork, and I also want to mention social worker, because Tina also worked very closely with the social workers in a variety of ways. And when they noted that a patient had distress, they would communicate that with Tina, and maybe Tina would see the patient in the inpatient setting, the outpatient setting, or maybe the patient would come to one of Tina's group classes. So I did want to say that distress was a very important component. Assessing distress was an important component of determining that yoga was an appropriate intervention. And it is actually listed in the NCCN guidelines that if a score of distress is a 4 or greater, they recommend for interventions, relaxation, meditation, and creative therapies. And yoga therapy fits into that.
Great, thank you, Gigi. I'm just going to jump in. We're running out of time, and we have two questions that I wanted to quickly ask you. So, hello, can you specify more details for yoga inpatient while they are in the bed?
Tina, did you talk about that?
Sure, yes. So if a patient tells me, well, the first thing I do is I say to the patient, your care is not going to be interrupted because I'm in here. There again, that safety component. They want to feel comfortable and safe to know that if they're needed by a nurse, she's going to come in even though I'm in there. So that's important, and that trust level. And then after I discuss things with patients, a lot of times I'm creating what I would call a yoga nidra. It is such an important practice. I do it more than anything else inpatient-wise because yoga nidra can be done by anyone regardless of their ability. And some patients don't even have the vitality enough to be seated upright. some patients have a hard time even breathing. So they're at such an acuity level that their breathing would cause anxiety. So what I do is guide them in a relaxation practice where typically I move to the belly, the rib cage, the trunk of the body to soften. Once they feel that softness and they get the idea that once they're so relaxed and soft without that habituated constant musculature needed from stress and pain, that pain can cause that type of holding so tightly. If I can get them to relax and soften, they can finally feel a little bit of relief. And for some people, Yoga Nidra really does work wonderfully inpatient wise. I think that's the number one thing I do the most is Yoga Nidra.
Yeah, let me just jump in.
Simplest of practices.
Yeah, let me just jump in and say that Tina pre-recorded a 20-minute Yoga Nidra experiential, and that has just been uploaded to SIO's YouTube channel. So it's there for you to watch it either now or later at your convenience. But Yoga Nidra is one of the most important practices that we can share with cancer patients or with anyone, either inpatient or during treatment. It's a special type of mindfulness meditation with some much more science behind it than I'm saying. We have, I promised I would keep this at 30 minutes today. We have 2 minutes left. Anyone in the audience that would like to ask question, please type it in. We do have another one, Gigi, for you. Just if you could quickly talk about massage therapy in cancer patients. This person has heard massage may contribute to the spread of the tumor.
And that's a false statement. I can tell you that in working with the massage therapist, that she would generally do very, very light massage therapy. And Cheryl and I actually published an article in Clinical Journal of Oncology Nursing in 2016. And if you go to Google Scholar and type in massage therapy, you'll find it. But the good results with massage therapy and cancer patients, and that is a falsehood that the massage therapy spreads the cancer.
Thank you, Gigi. I know that's a common question that cancer patients ask. We have one more question here, talking about the distress thermometer for the NCCN guidelines, and I just want to tell any cancer patients or advocates that there is a patient version of the distress guidelines. If you go to nccn.org. .org, yeah, and you scroll down, there's a professional guideline and then one version for patients, which I just read this morning, and it's very helpful, and the thermometer is on there. But the question is it routinely applied to all inpatients, this distress thermometer?
That's a very good question, and I would say that it's recommended to be so, but I think each hospital is struggling to kind of do that. I know when I was at Christ Hospital, we did have in our electronic medical record, we did add a line for assessing distress, but that is something that each hospital has to find a way to do.
Yeah, so I just will finish up in about 30 seconds. I just wanted to take a quick look in the chat. We've got several people asking if the definition for distress by the NCCN, the National Comprehensive Cancer Network, could be posted. And can you please type the website on the chat? I'm guessing that's the NCCN website.
Right, that is the website, nccn.org.
So I'm just gonna type that in for you. NCCN.
And if you go to nccn.org and you click on, I think it's like supportive management, and then you go down to distress, there's 2 documents. One is for professional and one is for patients. And in the professional document, that is where the definition for distress is in that document.
You know what I think we can also do for this definition is on the YouTube channel under the comments for Tina's Yoga Nidra, we can go in and put it in as a comment. So when you go in for your, to watch the video, it'll be there for you. Okay, I guess we'll wrap up now. Let me just take one more quick look. Thank you all so much for joining us today and talking about this really important topic of bringing mind-body practices to the point of care, not just in a community class or you know, in a group class in the hospital, but actually taking it to patients at the point of care during the chemotherapy infusion and to the bedside while they are inpatient. It's just an incredibly valuable practice for patients. Tina, Gigi, any last comments before we sign off?
Good luck. I would like to make one last comment.
Yeah.
Tina and I actually published an article in Oncology Issues. I don't know if you can see that.
There it is.
And this article was published in Oncology Issues, which is the Association of Community Cancer Centers, in July, August of 2019. And the article we published was how to implement a yoga therapy program at your hospital. So it might be something that, the article is called Integrating Yoga Therapy into Oncology Care. So that might be an article if you're interested in starting a yoga therapy program at your hospital. That article is a nice how-to article.
Yeah, you know what, that's great. This is it, actually. I printed it this morning. I will also put, is it okay, Gigi, if I put the PDF link for the article into the YouTube chat under the Yoga Nidra? Okay, so, okay, we're having lots of, yes, please, please. So we'll definitely do that. All right, thank you all so much for joining us. I want to thank our attendees who joined us today. Please come back next week, same place, same time for, actually next week's topic will be life cycle of a crisis and how mind-body practices can be useful to help us manage the stress of crisis. And okay, so thank you everyone, and thank SIO for supporting this Wellness Wednesday series, and we'll see you all next week.
Thank you.
Thank you.
Yeah, bye-bye.
Bye-bye.